Hello, hello, hello. Good afternoon, students. Good afternoon. Am I visible to all? Am I audible to all? Yes, thank you. And can somebody also type in the chat box so that I know that the chat box is also working? And so can somebody type? Yes. So welcome all of you to the November INI-CET OBGY recall session. And as all of you know, this is a recall session. So the exact MCQs, whatever we have tried to get from the students, from what all students who have messaged me, that is what we have got it. Some of the options may be slightly different. Some of the wordings may be slightly different. We can always try to come back with a perfect recall. We'll post the answers in our Telegram channel also and in the Insta also. But this is the recall from what the best situation which all of you have got. I hope all of you must have done extremely well because OBGY was very, very easy paper from what I saw. And trust me, so many students message me. It's a each and every MCQ was from your rocket revision session and also from your app lectures. So I request all of you, those who haven't yet installed the OGGuru app, quickly install the OGGuru app. 6 months for NEET PG. All of you can go in for the masterclass NEET PG where you get the entire theory lecture, rapid revision MCQs, and most importantly my personalized timetable and guidance. And all of you can get in touch with me on this number on phone and WhatsApp for the guidance available. I teach only OBGY, but timetable, guidance, strategy we provide for all 19 subjects. Okay, so you are free to tell me whatever are the changes in the option or what you thought were the options in your paper, whatever you could recall, and then we can also discuss it out. Okay, so let us begin the session and please do participate and all of you try to get me the answer. Yes, anybody, what was this? Very, very simple. So what is this? Primary patient has got urinary retention, amenorrhea. What kind of amenorrhea this we? Yes, Anukul, welcome. Okay, so what is this kind of a? Yes, we call this as primary amenorrhea, but this would be cryptomenorrhea. Yes or no? Crypto means hidden, cyclical abdominal pain and bluish bulge on the vagina. Anybody with the answer? I want all of you. Yes, very, very easy. Yes, MRKHNAIS would be primary amenorrhea, absent uterus, and the answer is imperforate hymen. This is a repeat topic, all of you, and this all of you know. TENS, and what is the treatment? Anybody? So TENS bulging hymen is shown to you, and there is, and anybody, can you tell me why there is urinary retention? Why should there be urinary retention? Very important. Yes, those who are joining in now, this is just the first MCQ of the session. Yes, okay, and please feel welcome if some wordings are different or something is different. Yes, anybody, why do you think there should be urinary retention? So the hematocolpus, the blood gets collected, the hematocolpus presses the bladder, and that would give rise to urinary retention. And TENS bulging hymen, okay, bluish purplish bulging hymen. And what is the treatment for this? Yeah, Omer, hello. And what is the treatment for this condition? Anybody, can you tell me the treatment? Very important. The treatment is a cruciate incision. The cruciate, you take a cross incision or a cruciate incision on the TENS bulging hymen and all the blood comes out. Okay, can anybody tell me which one more condition in the MCQ can also cause similar kind of presentation? So I'm trying to give you answer also plus give you knowledge also so that you learn something. So one more condition, sir, even a transverse vaginal septum will cause a primary amenorrhea, but then this bulge will not be there. The bluish bulge on the vagina, or that is the TENS bulging hymen. Okay, so that is why the answer is imperforate hymen. If the bulge is not mentioned, bluish bulge is not mentioned, then even transverse vaginal septum is one more condition where you get cryptomenorrhea. Crypto means the word is hidden. hidden menses. So this directly from my lecture cut, copy paste. We also have the image based question in this. Even in rocket revision INI-CET we had conducted, this MCQ was there. Yes, so very good Umair Shahzad. B option can also cause similar thing, लेकिन फिर उसमें bulging hymen will not be there or bluish bulge will not be there. Okay, is it understood to all of you? So very simple, imperforate hymen. And if we do ultrasonography, of course the uterus is present. Uterus is present. Very important, they may also tell you patient has a suprapubic bulge. The suprapubic bulge could be the bladder which is full or the uterus, because hematometra bhi hoga, hematocolpos. This blood is called hematocolpos, and this blood inside the uterus will be called as hematometra. And can anybody tell me long-term complication of this condition? Which one more these patients, the blood gets collected inside the uterus. So one more long-term complication, what can happen? The blood will go backflow. I'm giving you a clue. Chalo. Anybody? Which one more complication, long-term complication can be there? All of you please participate. Yes. Sir, the long-term complication, these patients have endometriosis as a long-term complication because of the backflow. So remember all these points, we can also get endometriosis, long-term complication of these patients. Okay, moving on to the, so I hope all of you must have got this correct, isn't it? Yes, easy, very easy MCQ. Yes. Now very important. I'm so happy we teach this every year. What is restitution? Anybody with the answer? What is restitution? Okay. This every year. Yes, so restitution means what? Anybody? Head rotation by 1/8 of a circle is the internal rotation. Internal rotation, the head can rotate by 1/8 or 2/8 of the circle, depending on 1/8 or 2/8, depending on where the head is, whether it's a LOA or LOT. This is the internal rotation. Okay, so labor begins with engagement. After engagement, there is internal rotation. After internal rotation, what happens? Anybody? Head keeps on. So there is internal rotation. Head keeps on coming down. There is crowning happening, and then the head delivery by extension. Anybody? Which maneuver do we do over here? Head delivery happens by extension. I have not yet given you the answer. Here, remember I show you in my image based MCQ, Ridgen maneuver or Ridgen maneuver is to be done for head delivery, and then after the head delivery, there is untwisting, because when the head has undergone internal rotation, there is a twist on the neck. So the untwisting of the neck, which is happening outside the body. All these parts are happening, all these things are happening inside, then the head deliver, and there is restitution. Okay, restitution is basically untwisting of the neck. I'm so happy this came for the first time. The MCQ did not been asked in the past, but it is very important. And then there is what? Then there is actually internal rotation of shoulders. Okay, there is actually internal rotation of shoulder, which is manifested as external rotation of the fetal head. Okay, external rotation of the baby's head. Is this understood to all of you? 5 thumbs up if all of you are understanding this. Is it clear? So shoulder undergoing rotation is the shoulder rotation taking place. That's not restitution. Head rotating outside the mother's body, outside the vagina, due to basically untwisting of the neck. That is restitution. Is this understood to all of you? All those joining in now also do participate. Please make it like a participating session so that all of you understand, all of you enjoy. Okay, and do share this video with all your friends and colleagues, and do hit the like button, and do comment also if some of the options which you felt were different or something was different. Yes, so important. Anybody? AMTSL, active management third stage labor. In fact, in the list of important topics, I had said that this question is surely going to come in. Okay, So active management third stage labor, which is not included. Can anybody tell me what is not included in the active management third stage labor? So please understand, there are three steps. There are three main steps in active management third stage labor. And what is the purpose of doing active management? Any idea? What is the purpose of doing active management? Okay, the purpose of doing the active management is, just a second. Yeah, the purpose of doing the active management is to prevent PPH, okay? The only purpose, it decreases the blood loss and for prevention of PPH, okay? So anybody, what are the three steps? Yes, point number one, we give oxytocin. How much oxytocin do we give? Sir, the oxytocin dose over here is 10 units and specifically intramuscular. So 10 units oxytocin intramuscular is given immediately after the delivery of the shoulder, specifically the anterior shoulder. Or remember one more definition, within 1 minute. Okay, within 1 minute of baby delivery is also okay. Okay, if you may not give directly at the time of the delivery of the anterior shoulder, within 1 minute of the baby delivery also we can give oxytocin. This is followed by control cord. Very good, Korean Jobby, 10 units and intramuscular. Excellent. Okay, this is followed by control cord traction to deliver the placenta. Anybody, what is the name of this maneuver? Chalo, extra knowledge, bonus information. Control cord traction, this is called as Brand-Andrews maneuver. This image also we show you in the lectures. Okay, Brand-Andrews maneuver. This is the control cord traction and this is followed by uterine massage after placental delivery. Bimanual compression is the answer. Bimanual compression, my dear students, is not a part of AMTSL. Bimanual compression we would do when there's actual PPH happening. AMTSL is for prevention of PPH. So when the actual PPH is happening, that time we may want to do a bimanual compression. We do it definitely, but that's not included in the AMTSL. Okay, so 10 units intramuscular injection after the delivery of the baby shoulder, followed by control cord traction, that is Brand-Andrews maneuver, and then uterine massage. Okay, and one more thing, please understand this. This is for the final year Viva student. The students tell me, okay sir, I will give oxytocin after the delivery of the anterior shoulder on the baby's anterior shoulder. तो ऐसा लेबर वार्ड में इंजेक्शन लेके मत खड़ा रहना एंड बेबी बॉर्न हो रहा है, हेलो बेबी हाउ आर यू, खटाक से यू गिव द इंजेक्शन. That's the first injection the baby will get in its life. Injection is given to the mother. Timing is in relation to baby's anterior shoulder. Okay, so injection is to the mother. वरना students और भी over smart होते हैं in Viva. Sir please, remember there was a medical joke circulating कि sir please चिल्ला के don't tell me कि anterior shoulder. It is understood, sir, that the injections are given on deltoid. So that is not the reason why we give the injection after the delivery of the anterior shoulder. We cannot give it before. What will happen if before both the shoulders are delivered, if I give oxytocin, the shoulder will get stuck. So before head delivery and before the shoulders are delivered, I cannot give oxytocin, the shoulders will get stuck. So only after the delivery of the anterior shoulder or within 1 minute of baby delivery, we give 10 units. That is AMTSL. Is this understood to all of you? Thumbs up. Okay. So that is what it is. But now students bolte hain, okay sir, what's the big deal to remember about anterior shoulder? Baby deliver hoga, shoulder dikhega, injection thok denge. Okay. So that's not the reason, okay sir, we want to give the injection on the deltoid. That's the reason we give after anterior shoulder. No, injection is given to the mother after the delivery of the baby or after the delivery of the anterior shoulder. Is this understood? So straightforward MCQ. I hope almost all of you would have got this correct, and I'm sure yes. I'm so happy. Very, very important MCQ. Anybody with the answer? So we have a patient of amenorrhea Now please tell me these values of LH and FSH. Are they high, normal or low? Yes, even in my lectures I had told you, okay, if you get 0.1, 0.2, 1, 2, anything less than 3 is considered low FSH LH. So master himself is sleeping. Yes or no? Master servant relationship. Anything, if you get the values 4, 5, 6, 7, 8, 9, 10, 3 to 10 or 4 to 10 is considered normal. And when they want to make the FSH on the higher side, they will say FSH is 15, 20, 30. That is the FSH is increased. Yes or no? So now can anybody tell me what is this condition? Yes. Athlete, many, athlete or some students may say athlete or also athlete was also given. Okay, athlete could be there. This could also be seen in the postpartum Sheehan syndrome. So what is this? Sir, the FSH and LH basically in the MCQ, FSH, LH both are very low. Both are very low, and therefore this is called as hypogonadotropic hypogonadism. Okay, sir, it is hypogonadism. Ovaries are not functioning and it is hypogonadotropic. FSH also low because FSH2, yes, they could have been slightly lower values, but LH 0.3. So when they want to give you 1.012, that is definitely on the lower side. If I twist the MCQ, and yeah, very thin build patient also. Okay, if I give the MCQ, can anybody tell me if instead of this 0.3, I make LH 30, FSH I make 20, then what becomes the answer? 2 ka I make it 20. Anybody? FSH I make 20-30 range. Then it will become hypergonadotropic hypogonadism. Is this understood to all of you? So next this question can come. So only one thing twisting can change the answer. Is this understood to all of you? So when the FSH is very low, it is basically a master problem. Master means the brain. It's a problem with the hypothalamus and the pituitary. Okay, and this kind of a report, when FSH, LH, very good, Kurian Jobi, absolutely correct. And when FSH and LH both are high, that is our ovarian failure. Yeah, Akshay, very good. Welcome to the session. I hope your paper was rocking and superb, and you must have done very well because all OBGY MCQs were from my lectures, isn't it? Yes. So in ovarian failure and when the patient is menopause, so this either when it's a primary ovarian failure, means ovary is at fault when it's a primary ovarian failure, or if the lady is approaching menopause, perimenopause or postmenopause, we get this kind of a report. Okay, sir, FSH, LH both will be very high. In our question, FSH, LH both are low. So the answer is option number 2, hypogonadotropic hypogonadism. This was probably the only clinical case scenario in the whole paper which we found, and this is very important. I'm so happy we have discussed this. Okay, so when the servant is sleeping, ovarian failure, menopause, FSH, LH all will become very high. Okay, and one more bonus thing, can you tell me when the patient reaches menopause, how much FSH? Yes, FSH will be increased, but how much? Can you tell me? Yes. Okay, anybody, how much will be the FSH increasing? Yes, specifically more than 40. This is also important. FSH more than 40 is diagnostic that the patient is menopausal. Okay, is this understood to all of you? So I repeat here, basically in the question paper, FSH both are very low or low, which is the indicating hypogonadotropic hypogonadism. I hope all of you must have got this correct. Yes. Anybody with the next MCQ answer? Not a indication for instrumental delivery or forceps or vacuum. Anybody with the answer? So superb and so important, and I'm so happy because it's one of the prerequisite. Anybody with the answer? I'm sure all of you must have got this correct. Yes or no? Umair, Korean? Yes. So point number 1, for forceps or vacuum, cervix when it's fully dilated, suppose it's 10 centimeter, and what should be the station also? Anybody? What should be the station at least? Okay, sir, the station to apply forceps or vacuum should be at least +2. So much extra information we are giving you. When the mother is exhausted, definitely we apply the instrument, prolong second stage or even cut short second stage. Okay, cut short second stage in the cases of heart disease patient. Heart disease, I don't want the mother to do too much bearing down. Yes, very good. And of course fetal distress, when the baby heart rate is dropping down, time is crucial, forceps is even faster than the LSCS. And very good, CPD. I'm so happy I teach this the first thing when I start. Okay sir, what is the requirement? Yes, okay sir, the pelvis should be adequate. Whenever we are applying the instrument, whether forceps or vacuum, pelvis should be adequate. If there is CPD, there is no point applying the instrumental delivery. So never mark CPD or never say in the Viva CPD as an answer. CPD is a contraindication. CPD is not an indication. If it's a CPD, we will go and do LSCS directly, but no instrumental delivery. Okay, no instrumental delivery. Okay, because pelvis should be adequate is a prerequisite for applying forceps or vacuum. Pelvis adequate matlab no CPD, no cephalopelvic disproportion. Is this understood to all of you? Why? Because sir, if there is no space only for the baby to come out, CPD matlab the head is very big. Okay, the head is very big, or the pelvis is narrow, then what is the point? There is no point applying the instrumentation. Do you agree with me or not? What is the point of applying the instrumental delivery and getting the forceps out if the baby itself is not going to come out? So whenever we apply the instrument, there should be basically no cephalopelvic disproportion. There should be adequate space for the baby to come out. Then only I will apply the instruments. Okay, so all those who are joining in now and after the stream is over, do go back and check out the first, because we have discussed already 4-5 MCQs. Very important discussion we have done of the previous 2 MCQs. Okay, so I hope all of you must have got this correct. Straightforward, simple MCQ. Yes, again I am so happy. Unexplained infertility. What percent of cases are unexplained? In what percent of infertile cases? Infertile patients was asked. And yes, we know, we roughly say that it is around 30 to 35 to 40-50% is a male factor, a female factor, 30 to 35% is female factor. And when what is the meaning of unexplained infertility? Sir, all possible investigations are normal. When all possible investigations are normal, roughly we say 10% cases, 10%, and yes, roughly 10 to 15%. So we will mark 10 to 15%. Thoda sa zyada diya hai. 5 is FS. So they should have said 10. We would have been more happy. 30, 25 nahi hota hai. 10 to 15% cases are unexplained infertility. By unexplained infertility, we mean it's all male-female investigations, all possible investigations which are possible we have done and they are normal. Bad luck, we do not know why the patient is infertile. Okay, so numerical thing, you just have to mug up this. Yes, now early pre-eclampsia, all of you know pre-eclampsia is always after 20 weeks. And what can be used, anybody, for prediction of pre-eclampsia? Anybody? How can I predict? So for prediction of pre-eclampsia, we can use, this is just a extra information. Prediction of pre-eclampsia, we can use color Doppler. Color Doppler we can use. And what? Maternal uterine artery color Doppler. This MCQ will come in the future exams. And can anybody tell me what can be given for prevention of pre-eclampsia? Very important MCQ waiting to come in the upcoming exam. For prevention of pre-eclampsia, which drug is available? Okay, and early onset is the one before 34 weeks the pre-eclampsia develops, or which actually requires even a delivery before 34 weeks. Okay, and if the BP is so high and I need to deliver before 34 weeks. Okay, so that is early onset. Pre-eclampsia is always after 20 weeks, and in this early onset is one which starts developing at 30, 32, 33 weeks. Okay, so before the 34 weeks is considered as your early onset preeclampsia. After that, and 36, 37 weeks, after 37 weeks is late onset. Okay, we also can classify it as non-severe and severe. Okay, yeah, yes. Okay, prevention of preeclampsia, what can be given? Ecosprin, low dose aspirin. How much low dose aspirin? 75 to 150, 75 to 150 milligram. Okay, remember this. This is also a Virgin MCQ waiting to be coming in the future exams. Okay, low dose aspirin, 75 to 100 milligram. We can start as early as soon as the patient conceives. Okay, this is for prevention of preeclampsia. Okay, low dose aspirin. Okay, yes. And maternal uterine artery color Doppler, diastolic notch, and in the first trimester the increase in PI, increased pulsatility index, in the maternal uterine artery color Doppler. Okay, is it understood to all of you? Yes. Now anybody? Yes, very good. Antioxidants can also be given. Very good, Akshay Purvat. Very good, excellent. Okay, now what is this? Anybody? कैसे हमने बताया था आपको? Yes. Okay, yes, excellent. Okay, so there is the pubic symphysis. There is the pubic symphysis, and on the back of the pubic symphysis, slight bulge. Okay, and what is to be remembered? TOD. TOD matlab true obstetric diagonal. TOD. So from the sacral promontory, midpoint. Okay, if from the upper part of pubic symphysis, this is the pubic symphysis, PS I am writing. What is this? And similarly from the sacral promontory to the midpoint of pubic symphysis, and from the sacral promontory to the lower border of pubic symphysis. So ये तीन हमने draw किया है, 3 lines. Can you tell me which is the first line, which is the second line, and which is the third line? Anybody discussed in my lectures also. So this is your TOD. The way to remember this is TOD, matlab your true conjugate, obstetric conjugate, diagonal conjugate. Which is the only one which can I measure by doing PV examination? Anybody? And how to remember? Okay, so clap if you feel happy. Clap if you feel happy. कैसे याद रखना है? कैसे याद रखना है? Okay, all of you, this is our pubic symphysis. So O के बाजू में again O and 0 is the same. So this is 10 centimeters. Isn't it all of you? O and 0 same. Clap. एक ऊपर add 1, 11, add 2, 12. So this is basically 11, 10, and 12 centimeter. Clap if you feel happy. And therefore the answer is obstetric conjugate is the shortest. Obstetric conjugate is the shortest. Yes, thank you very much. Okay, so clap if you write. So 10, 0 and 10 yaad rakh lo, O and 10. Fir go up, add 1. Go down, add 2. So 11, 10, 12. So this is 11 centimeter. This, my dear student, is 10 centimeter. This, my dear student, is 12. And can anybody tell me, if they ask you next year, which is the one which I can measure by doing PV examination? I can never measure the T and the O. Anybody? When I do a PV, we do a PV from the lower border of pubic symphysis. So diagonal conjugate is what we actually can able to calculate by doing a PV examination. That when you actually become a gynecologist, come to the wards, I will teach you. Okay, because from lower border of pubic symphysis, from here I will do the PV. There is the vagina. So we put the fingers here and we try to reach the sacral promontory and you measure it and you get the diagonal conjugate. From that you subtract 1, you will get 11. From that you subtract 2, you will get the obstetrics. Okay, is this understood? So shortest diameter obstetric conjugate. Okay, now I will require some help in the video. Very simple, but if anybody can put the exact correct option, that will be great. Some ectopic pregnancy, whether some clinical case was given or some history of ectopic pregnancy which was given in the patient, or some clinical case basically which from where we know the diagnosis was ectopic pregnancy, and choose the incorrect statement. And so simple, so easy. Yes, a pelvic inflammatory disease or previous ectopic pregnancy is a risk factor. Pain can happen. I told you pain is the most constant feature. Pain is the commonest presenting feature. What is the classical triad? Sir, bleeding PV, history of amenorrhea, and pain in the lower abdomen or pelvis are the triad of ectopic, but not specific for ectopic pregnancy. Pain is the most constant feature. I've said this in my video lectures also. And we told you that sir, HCG is not rising and levels of progesterone are lesser but not diagnostic. Yes, so that is also correct, that progesterone levels are also on the lower side, but it is not diagnostic because even a failed pregnancy may have very low levels. And this, my dear students, simple answer, methotrexate is given. Some students told me oral methotrexate. Was oral word given? Anyway, oral nahi dete hain. But I am also not given if the patient is in shock. Anybody? If the patient is in shock, what do we do? The patient is in shock. We have to immediately, basically, it means it's a ruptured ectopic pregnancy. The preferred, of course, after stabilizing the patient, the surgery is the definitive management. Methotrexate is given only in unruptured ectopic pregnancy, that all of you know. Yes or no? Unruptured ectopic and stable patient. And we know the size criteria. In fact, in my prediction reel also I had said, okay, go and do the ectopic and methotrexate in the last few days before the revision, before your INI-CET. Yes, so oral was there. Yes, okay Rahul, thank you. Yeah, so oral anyway nahi dete hain, oral to anyway nahi dete hain, and IM also you do not give the patient is in shock. Yes, so oral methotrexate given. If the patient has some renal failure also, some told me sir, if patient has some renal failure, oral. But anyway, oral methotrexate we are not giving, we give IM only, but that is the incorrect statement. Okay, so methotrexate if we give is always IM. Okay, so MTX when we give, it is always intramuscular route. Okay, yes. Anything else? Yes, very good. Okay, moving on to this. Okay, so this was a secretory endometrium. The beginning of the classes we explained to you, proliferative endometrium is because of your estrogen. Estrogen will make the endometrium proliferative, and this is your physiology. And then progesterone converts the proliferative endometrium to a secretory endometrium. And in early pregnancy or even in normal patient, the progesterone comes from corpus luteum. Those who have attended the lecture know this case, sir. Ovulation, corpus luteum, progesterone. Yes or no? And therefore, if no ovulation, no corpus luteum, no progesterone. Yes or no? Yes. So corpus luteum is the answer. Corpus luteum secretes the progesterone, which is responsible for secretory endometrium or presence of corkscrew glands. Okay, corkscrew glands is also a part of secretory endometrium. So whatever may be the wordings in the question paper, this was the answer. Yes or no? Yes. Okay. But a granulosa cell will be, FSH will be acting and they will be secret. Okay, so testosterone will come from the theca cell and estrogen. Okay, so this. Okay. Now, female, this is very simple, nothing to be discussed. Vaginal discharge and positive whiff test. So that is our bacterial vaginosis. Okay, malodorous discharge, grayish white discharge, positive whiff test. So many times we had said that one MCQ from vaginal discharge already comes, and even presence of clue cells. Okay, so that is the positive whiff test, which we get when we take the secretions and we add 10% KOH, 10% KOH, we get the fishy odor. Okay, we get a fishy odor, which is positive whiff test. Again, surely repeat question and will be coming for many years also. Every year this question comes. Nothing much of discussion over here. Yes. Now I'm so happy. What the mistake students do is they don't read all the option. When the question come, when is delayed cord clamping done, directly first they are marking vigorous term babies. Yes, vigorous term baby is there. But what is the better answer to mark? And I had said this, that there is a new change in the guidelines, that the old concept was that sir, only for term babies we do delayed cord clamping. And preterm babies, if we do delayed cord clamping, more blood will go, they will have failure. That was the old concept. I told you that as per the latest guidelines, even in preterm, as long as the baby, whether the baby is term or preterm, if the baby is vigorous and crying and they do not require any resuscitation, we will go for delayed cord clamping. Okay. Okay. Okay, so the answer is vigorous term and preterm babies not requiring resuscitation. Okay, so both term and preterm babies we are going to, if as long as. So when do we have to do, anybody can you tell me where do we do early cord clamping? So sir, early cord clamping is done when there is baby is requiring resuscitation. If any newborn, okay, if the baby needs to be going to NICU or some resuscitation is required, and which other condition, anybody, if resuscitation is required. And also remember RH iso immunization. Why, anybody? Because sir, in RH iso immunization, this antibody will cause fetal hemolysis. So not RH negative pregnancy, but if I do if the antibody is already present, that means it is RH isoimmunization. If I do delayed cord clamping, it will be fetal hemolysis. Yes, fetal distress of course is correct. Very good. So in fetal distress, where we have to do resuscitation, we do early cord clamping. And also remember one more, RH isoimmunization also, because if we do delayed over here, there's going to be more fetal hemolysis. Okay. No matter 34 weeks is what it is. Yeah, you are correct. Anytime of 24 weeks, 26 early means their development is at 26, 28 weeks. You're correct, but technical definition is before 34. Okay. So vigorous term and preterm babies not requiring resuscitation. Here we go for delayed cord clamping. Okay. So I hope all of you must have got this correct. Yes, again, very simple. Dysgerminoma, yolk sac, which is not a germ cell tumor. Okay, granulosa cell tumor is your granulosa and theca cell is your sex cord stromal tumor. Okay. So that is your, okay, that's your sex cord stromal tumor. That is not a germ cell tumor. Pathology MCQ, you can consider this or whatever. We have discussed this dysgerminoma, yolk sac, all come from the germ cell. Okay. Anybody for your yolk sac tumor, alpha fetoprotein is the tumor marker. Choriocarcinoma, HCG is the tumor marker. Okay, just extra information. Okay, yes. Now, yes, again, so simple, so easy. Physiological changes are all except. So what is going to happen? There is insulin resistance. Anybody, why? Which hormone? Chalo, which extra knowledge? Which hormone of pregnancy will cause insulin resistance? And blood volume definitely increases, cardiac output also increases. Progesterone hereafter, that is correct. Very good. Yeah, very good, Akshay. You remember that words. Thank you. Okay, yes. So, sir, estrogen, progesterone, and HPL. Human placental lactogen is responsible for development of insulin resistance. Very good, international affairs, very good. Yes, excellent. So HPL, human placental lactogen, are responsible for insulin resistance. RBC mass may also increase. Very good, Shivani Singh. We don't get increase in the blood pressure. In fact, there's going to be a fall, which is very good. There's going to be a fall in the, that's why sometimes the pregnant ladies, they feel sir thoda sa giddiness, chakkar jaisa aata hai. Okay. So the decrease in the blood pressure happens because there's going to be peripheral vascular resistance is going to be low, and that leads to decrease in the blood pressure. Okay. So all except increase nahi hoga. this is the decrease. Okay, so that was a straightforward MCQ. All of you must have got this correct. Okay, now yes, here I require some students' help. Please tell me the exact thing. I'll tell you what are the option according to me. Something is not matching actually, because when they say 14 weeks mass, I think para 1 living 1 was given. So whether the lady was pregnant or not, we do not know. But if it's a 14 weeks mass, means a huge size, but then 8 by 5 centimeter does not match, because then it should have been very big, say 10-15 centimeter. Reticular shadow, however, reticular shadow means like a blood. Okay, so blood or hemorrhagic. Okay, so if it's a clear cyst or a unilocular cyst was also mentioned, can anybody tell me? Yes, the important part is RHD on warfarin. Okay, now here please understand whatever I told you from Novax. Okay, sir, if the mass is more than 8 centimeters, then definitely we go for surgery. Or if there's a pain. Okay, so some of you can please tell me exactly what was the MCQ, because we are getting different questions for this. So if somebody can tell me the exact wordings of the MCQ and the exact size, that will be slightly helpful in giving the answer. Because there are two answers possible for this. We are not going to do CA 125 in a 24-year-old. CA 125 is for your epithelial cancer, which is after 40, 50, 55, 60 plus postmenopausal ladies. Okay, again MRI is not required. See, if it is only 5-6 centimeter cyst, which the question is, we can do a follow-up. If it is more than 8 centimeters, see, we know it's a reticular shadow. Reticular, just fine thin strands. So this is more of just a blood or a hemorrhagic cyst, which can resolve on its own because the patient may be on warfarin. If it is torsion, severe pain, if the size is more than 8 centimeter, or if there are solid areas, then definitely we do a surgery. Is this understood? And all postmenopausal lady, yes or no? So all of you know, okay, sir, if the lady is postmenopausal, all postmenopausal lady, whatever may be the size, let it be 4 centimeter, 5 centimeter, 6 centimeter, we go for surgery whenever in all post PM matlab postmenopausal. Okay. And when the lady is before menopause, pre-menopause, or in the reproductive age group, more than 8 centimeter goes in for a surgery. And torsion, immediate surgery, torsion. And if it is less than 8 centimeter and it's a clear cyst, then we can wait and watch. If there are solid areas, we again do a surgery. Isn't it this flowchart we teach every year in the lectures? And this. No, beta. Shivani, it is not RHD and ovarian mass. The connection is that, sir, if the patient is on warfarin, so RHD patients do not have more risk of ovarian mass. Okay, Dr. Shivani, here what is basically, it's a bleeding. Because when the patient is on warfarin for metallic valves, there's slight tendency for bleeding. So these patients may work by giving them, if you give them an ovulation, or if you suppress the ovulation, then they might be better. They can give a long-term progesterone like a DMP or something, may work. Okay, so here the question was that I am also, as I said, okay, this is just a recall thing. If the question was there is torsion, like severe pain, or solid areas mentioned, or the size was more than 8 centimeter, my answer would be surgery. 8 by 5 is just a cutoff of 8, and we know she is a heart disease patient, unnecessary. Why? We can do a follow up. But if you tell me, sir, it was 8-9 centimeter mass for sure, then surgical exploration also may be required. So as I said that torsion, severe pain, or any solid areas. By solid areas, I mean which is looking like cancer. Solid inside or solid like a papillary growth on the external. These diagrams I draw in the lecture and show you. Yes or no? Then definitely the answer is surgery. If it is just a reticular shadow, means it's definitely a blood. It's mainly like a hemorrhagic cyst. But still 14 weeks mass is a huge, but it's 5 centimeter is not big. They should have given just 4-5 centimeter mass. Follow up, I feel, is the best answer. Again, let us, this is slightly depending on exact what is the recall word we get. Yes, very, very important. ACOG, the pap smear guidelines. Anybody So all of you know, and low resource setting. Okay, low resource settings. Okay, so what is the answer? Anybody, what is the answer? So sir, in the best of situation, okay, so pap smear starts from 21 years to 65 years every 3 yearly. Okay, every 3 yearly we do the pap. So pap smear only in high risk individuals? No, pap smear every 3 yearly. Okay, pap smear every 3 yearly. Very good. International affairs sees dance. Okay, best is what is the co-test? Anybody, what is co-testing? Yes, that is the best, but here clearly low resource bola hai, तो HPV DNA testing is not available everywhere. It's only available in few cities and this. So HPV DNA testing, or basically HPV testing, HPV typing it is called as, that is the co-test which you do every 5 yearly. So that is considered the best. Wherever possible it is preferred, but otherwise a normal pap smear test every 3 yearly we should do, starting from 21 years to 65 years every 3 years. So that is the answer. Yes, I agree. All of you must have got this correct. If they tell you, if I doing a code, yes, PAP and HPV both better, then you do 5 yearly. So co-test is 5 yearly. Very good. That is 5 yearly. Co-test is absolutely correct. This option B. Combination of PAP test. When you do co-testing is combination of PAP, and by this PAP I mean liquid based cytology. We have to do liquid based cytology and then we do HPV. Yes, very good, Ritabrata. Welcome to the stream, and I'm sure you must have done very well because everything was from our lecture. Yes or no? Yes. So pap smear every 3 yearly is the answer over here, because it is low resources mentioned in the question paper. Yes. Now again over here thoda sa slight students are debating, and we have to again verify the exact option. And quadruple marker test, all of you know, it is inhibin A. Inhibin A is what we do in quadruple marker. Yeah, beta. Aditya Jain, question AMTSL, oxytocin can be given. Yes, after the delivery of the. But it's correct. But Aditya Jain, you can go and check the Aditya Jani. You can go and check the video. We have said, but beta, bimanual, like bimanual compression is the answer, because bimanual compression is when actual PPH is happening. Okay, beta. So bimanual compression will be the answer. So those who have joined the stream late, go back and see that MCQ have discussed. But thank you for telling me. Yes, so after the delivery, while they're delivering, and after delivery of the anterior shoulder, or within 1 minute, that's still fine. Bimanual compression will be the answer. So here what all of you know, HCG, what are the options for what is this? Yes, now it should be estriol, unconjugated estriol. Estradiol is not a part. So if both the options were there, okay, both the options are there, if both the options are there, then estradiol also is wrong, because estradiol is not done. But some students told me, no sir, estriol was there. So basically all of you know, HCG, alpha fetoprotein, unconjugated estriol. This is my triple marker test done between 16 to 18 weeks of gestation. And to this, when we add inhibin A, even when a reel I had made on the Insta for prediction 3 days before, I said, okay, do everything with trisomy screening, one MCQ will surely come, and we were very accurate. Okay, so inhibin A is a part of quadruple marker test. Inhibin A is higher than normal. HCG is also higher than normal. AFP and unconjugated estriol are lesser. Yes, so this becomes the answer, because यहाँ पे clearly inhibin B दिया था, it is inhibin A. Okay, but I know कि if estradiol दिया है, that is also wrong, because estradiol नहीं होता है, it is always unconjugated estriol. The way to remember it is, as I said, triple marker test. So triple matlab 3, and therefore in the option also 3 should come. Clap if you feel happy. So 3 is triple and unconjugated estriol. Estriol is again with a 3. Okay, yes, so that was it. And one of the MCQ, I think we are not too sure, some cancers and serum marker, was it match the following type of MCQ, was it there, where some options were there. And then also this MCQ, we know matlab ke for your epithelial tumor, means this also we have discussed in the lecture. Epithelial cancer, CA125 is the tumor marker. For dysgerminoma, LDH is the tumor marker. And for yolk sac tumor, alpha fetoprotein is the tumor marker. So what if exactly this was there? No, but Bruce, I agree with you, Dr. Bruce, but I told you that technically the definition, okay, technical definition is before 34 weeks. I agree with you. Okay, yes, early onset would be, in practice, what we see the patients is, you are correct, Dr. Bruce, that it's a 26 weeks, 28 weeks. When I see preeclampsia, we call it as early onset, definitely. But the technical definition goes that, sir, when the eclampsia develops before 34 weeks, you call it as early onset, or which requires delivery before 34 weeks. And then one which is developing later on at say 36, 37 weeks, and later on towards the end 37, that is called as a late onset. Okay. Yes, so I got your point, Dr. Bruce, that you are correct, and this, and yes, okay. So I hope all of you had a great time in today's session. Almost all 18, 19 questions, and one was about the sperm mitochondria, that's anatomy MCQ, which you can see, or embryology, the sperm head, there is the mitochondria in the neck piece and the connecting piece. Okay, so these are all the MCQs which we got in the recall. Please feel free to put in the comment if some options were changing or some options were different. We can always come back and refine this. And as the last thing, students, I request all of you to install the OGGuru app, whether it was INI-CET, May, or this, and even this year NEET PG, all 2022 questions were from my videos. So all of you will tremendously benefit, and all of you can just take 6 months master class. 6 months master class. Do take in and subscribe. I'm personally guiding all the students. Beautiful handwritten notes are there. There are theory lectures, rapid revision MCQ, all the latest guidelines, and you will love the lecture. I can assure you that OBGY will become your most favorite subject and most scoring subject when you walk out of the NEET PG 2025. So many students messaged me and called me also personally and said that, sir, when we came off the NEET PG 2024, sir, most confident we were in OBGY, and my best performance was in OBGY. And I can assure you, same thing will happen. So master class, it's just 1700 rupees, 1749 to precise, for 6 months. You will get all the theoretical concepts, all the images, all the rapid revision MCQs, and beautiful handwritten notes are also there. And plus, of course, my timetable and guidance. So many of you are directly in touch with me on phone and WhatsApp. So my students can call me, WhatsApp me, and download the OGGuru app and go for 6 months masterclass. Launch 30 is the discount coupon, and you will definitely benefit from the lecture. Yes, okay. Great. Thank you. That's super. Yeah, that's the benefit fee. Okay. So I wishing you all the best. I'm sure all of you must have done very well in the INI-CET, and wishing you best of luck for the upcoming NEET PG also. Do share this video with all your friends. Do also follow me on Insta, because regularly we post the MCQs also. And definitely install the OGGuru app and follow me on YouTube. And I wish all of you best of luck, and you can go in for the 6 months masterclass. You will definitely benefit from the lecture. Bye bye. Best of luck. Thank you very much, and see you soon.